Thank you for inviting me. Good evening. So if we considered 100 colon cancer, there is several phenotypes that have been recognized during the past decade. And the first one is MSI phenotype, which is a microsatellite instability phenotype, which represents approximately 10 to 15% of colon cancer. As you can see here, there is an overrepresentation in this subgroup of BRAF mutation, and most of these colon cancer are localized in the right or the proximal part of the colon. The second phenotype is, this MSI phenotype is due to defect in the mismatch repair system. So this is a very schematic representation of a replication fork of the DNA, and the polymerase that replicate the DNA make some errors, and this error is more frequent in some repeated sequences. That's the name for a microsatellite. In fact, microsatellites mean a repeated sequence of mononucleotide, dinucleotide, trinucleotide, or until pentanucleotide. And in this repeated sequence, there is an accumulation of error by the polymerase. These errors are corrected by the mismatch repair system. First, this error in the replication induces a modification of the conformation, which is recognized by one protein, the MSH2 protein, which is blocked by this modification of conformation. And then there is a second protein that are recruited, MSH6 or MSH3, depending on the type of error or modification in the DNA. Then these complex, MSH2, MSH6, for example, recruit PMS2 and MLH1 to repair this error by excision, resynthesis of the new DNA strand, and a ligation. So if you have this MSI phenotype, you also have hypermethylation phenotype, which could be associated with the MSI phenotype. This hypermethylation in the enhancer region of the genes, in fact, induce, in some cases, an hypermethylation of MLH1, which induce the MSI phenotype, because you have a defect in one of the protein of the complex, and you have no more HMLH1 protein in your cells, so you have this MSI phenotype due to a hypermethylation of the enhancer region of this gene. So this hypermethylated phenotype account approximately for 15 to 20% of the tumors. So you have in one side the double phenotype, MSI phenotype plus MSI phenotype, and you have these blue tumor, let's say between 3 to 5% of the colon cancer, that have only the MSI phenotype. And this is due to a germline mutation in one of the protein. The most frequent is MLH1, followed by MSH2, and less frequently by MHS6, and very rarely by PMS2. So that explains the different phenotype. And I would like to finish by the last phenotype, the hypermethylated phenotype, which is due to a defect or an alteration of a poly E or poly D, polymerase eta or polymerase D1, which account approximately for 2% of the colon cancer. And finally, we have this chromosomal instability phenotype, which account for 70 to 80% of all colon cancer, with an overrepresentation of distal cancer and with an overrepresentation of KRAS mutation in this subgroup. So, to summarize this, there is three alterations that are approximately present in 15% of colon cancer, and you can see in this slide that there is a strong overlap between the different phenotypes. 15% of MSI high, 50% of hypermethylation, SIM phenotype, and approximately 15% of BRAF mutation. And as you can see, there is most of the tumor have the three phenotypes together, MLH1 hypermethylation associated with a BRAF mutation associated with a MSI phenotype. So all cases with a hypermethylation of MLH1 are MSI high, but only 75% to 80% of the cases with MSI high show a MLH1 hypermethylation. So why we need to test MSI phenotype? This is a recommendation published recently. And the sentence is in red. Clinicians should order mismatch repair status testing in patients with colorectal cancer for identification of patient at high risk for Lynch syndrome, to recognize the germline mutation of one of the protein, and or for prognostic stratification. If we consider these as prognostic markers, you know that MSI tumors have a better prognostic than the other. And if we try to measure, in fact, the variance, the proportion of the variance of these markers as a prognostic markers in the term of survival in multivariate analysis, you can see in these meta-analysis of different series that approximately 3% of the overall explained variance in terms of survival is due to the MSI phenotype, which is represented here in blue, 3% for observational study and 3% for observational study, the clinical trial, sorry. And this part of the variants that are explained by MSI phenotype is on the same range. That's what is observed for BRAF mutation or KRAS mutation. And you can see we explain, in fact, only 3% of the prognostic by the MSI phenotype. But also we need to recognize the MSI phenotype to use immunotherapy, as you know. So how we can summarize this? How can we recognize, the microsatellite loci? In fact, you have inherited one chromosome from your mother and one chromosome from your father. And since there is some accumulation of error in these microsatellite loci, which is represented here by these repeated D-nucleotides, in fact, these regions of the genome are highly polymorphic in the population, in the human population. So that means that the length of this repeat is different between the individuals. So you can recognize chromosome inherited from your mother or your father. If you amplify these loci, you are able to distinguish, just by a migration in electrophoresis, by the size of the allele, you are able to distinguish these two alleles. So what we observed, let's say 10 years ago or 20 years ago, that in some cases you have lost one allele in the tumors, in the DNA extracted from the tumor, which is due to the loss of the segment of the chromosome that bear these loci. And in MSI phenotype, which is a microsatellite instability, is due, in fact, in the accumulation of new alleles in the tumors. And this new allele is just due to the replication error that occurs at each cell division, and that accumulate, because when you take a fragment of the tumor, you take millions of cells, and you extract DNA from millions of cells, and so you observe the accumulation of error in the DNA. So you can also determine the status by studying the protein and by measuring the protein expression by immunochemistry. And so you have antibodies, again, MLH1, MSH2, MSH6, and PMS2. And you observe the lack of protein expression in the tumor cells as compared to the normal cells, which is represented here. Here you have normal cells and tumor cells that express, so you have MSS tumors. And here you have, in normal cells, the expression of the protein and none in the tumor cells. And you can also study the MSI status, as I already mentioned, by molecular biology, by Amplify. And in fact, now there is a well-recognized test using 5 markers, and you can conclude that you have a MSI status if at least 2 or 3 markers are unstable. So these 2 tests, in fact, have been compared between them. And in fact, the efficacy of the test to recognize the MSI phenotype depends on the population you considered, as you can see in this slide. If you consider the detection using immunochemistry, the loss of one of the 4 protein, or if you consider the detection using molecular biology, what you observed, if you have a population of probable sporadic deficient mismatch repair colon cancer subgroup, in fact you have, and you detect 88% by immunochemistry, 95% by molecular biology, and if you proceed both tests, you have 100% of the detection of the MSI tumors. If you want to recognize Lynch, if you have a population of Lynch syndrome, in fact, you have a similar efficacy for the 2 tests. And if you have an indeterminate subgroup, there is a more pronounced difference between the 2 tests, with 89% of detection by immunochemistry as compared to the 99.7% for molecular biology. Oops. So, in fact, the information given by immunochemistry and molecular biology is different. If you consider molecular biology, you can say you have a MSI phenotype. Now, if you consider immunochemistry associated or not with molecular biology, if you have a loss of expression of MSH2 and MSH6, your conclusion is probably a Lynch syndrome associated with MSH2 mutation, and there is an indication to look for mutation in germline mutation in MSH2. If you have a loss of MSH6 alone, in fact, it is an indication to look for a germline mutation in MSH6. In fact, when you lose MSH2 expression, in fact, there is an interaction with MSH6, so you lose the expression of the 2 proteins. Consider MLH1 and PMS2. You have to consider BRAF. If there is a BRAF mutation, it is a sporadic deficient mismatch repair tumor due to an extinction by hypermethylation of the promoter of the gene HMLH1. If you have a BRAF mutation associated with the loss of expression of MLH1 and PMS2, in fact, you can have 2 type of conclusion. Your MLH1, you can test the hypermethylation of the promoter region of MLH1. If it's present, is in most of the cases a sporadic DMMR tumors. But there is some trap because it is possible that there is a constitutive hypermethylation of the MLH1 gene, and this is inherited, and it is a Lynch syndrome. So if you have the second possibility is a MLH1 non-hypermethylated, so it is a germline mutation that is and the loss, of heterozygosity of MLH1 is in these cases due to a germline mutation of MLH1. Finally, the last conclusion is the loss of PMS protein expression alone, and in these cases, this is a Lynch syndrome associated with PMS2. There is alternate method to detect the MSI. The first one is from a French group that describe, in fact, a mononucleotide, a repeat sequence of 17T in one gene, the HSP110, which is a gene, and you have this repeated sequence present here in just before the exon 9 of the gene. So this sequence is an intronic sequence in the intron 8 of these genes. And this group demonstrate that most all tumors with a MSI phenotype have an alteration of this repeated sequence of 17T with a deletion or an insertion of this T. And these induced, in fact, the skipping of the exon 9. So they compare the 5 classical microsatellite markers with different cutoff of 2 or 3 with their markers, HSP 110. And as you can see, there is a good correlation between the different tests with a sensitivity very similar between the tests, a specificity very similar, and a predictive value, positive value, and a negative predictive value, excellent. So these markers, these unique markers, can replace the 5 previous markers. The second alternate method that can be used is sequencing. This is the first example of what has been performed by this group. They test 275 genes, and they look, in fact, they have 2 cutoffs. One cutoff for the number of mutations, 40 mutations per megabase, and the number of indels in repeated regions superior to 5. So this is the cutoffs that are present by the line here. And as you can see, you have the mismatch deficiency tumors in red and the proficient mismatch repair tumor in green. As you can see, there is in the training group a very good correlation with these different cutoffs, and also for the validation. Just mention this tumor in red, so misclassified by sequencing, but in fact this patient, it's one patient with 2 tumors, one DMMR and one proficient mismatch repair. And in the validation setting, you have here these 2 false, let's say false positive of the test by sequencing, with a total number per megabase very high. In fact, this 2 tumor is due to a pole E and a pole D alteration, inducing a large number of mutations. But it is important to recognize this 2 tumor because probably they could be treated by immunotherapy due to a high mutation load. You can also distinguish by sequencing these 2 types of tumors, the DMMR and the pole E, by the signature of the mutation. And as you can see here, there is a huge difference in terms of signature due to these 2 alterations. There is several other publications in sequencing, one using exome as sequencing, so they sequence 44 megabase and approximately 30,000 genes. And as you can see, you can very easily distinguish MSI positive tumor and MSI negative tumors very easily. If you sequence only 50 genes, there is an overlap between MSI positive and MSI negative tumors. But if you increase the number of genes and if you select some intron implicated in structural rearrangement, you can improve the difference between MSI and MSI negative. Finally, there is a recent publication showing, in fact, a difference, trying to define a panel of genes, allowing to distinguish MSI from MSS tumors. They use, in fact, the biomarkers plus several genes, which is important in colon cancer. And as you can see, they distinguish between MSI negative and MSI positive with a score at 0.4 as a cutoff. But you can see there is some discrepant results. One is due to a loss of MSH6 protein expression, and they found in these tumor, which is negative in MSI by classical method, they found in fact MSH6 germline mutation. And in these two cases, it was MSI positive by molecular biology, but with immunochemistry, they did not find any protein extinction. So this can be considered as a false positive of the molecular biology MSI phenotype. And there is probably one that are missed by sequencing, is a patient truly false negative with a MSH germline mutation. So in conclusion, the MSI phenotype should be performed for all colon cancer beyond the aim of Lynch syndrome identification to treat them. Several methods exist and they bring different information. Immunochemistry to characterize the 4 proteins, and molecular biology, and there is several different techniques, pentaplex, the 5 markers, or the mononucleotide in the HSP 110, or NGS. And the place of NGS should be rapidly evaluated in large series, and the inclusion of dedicated targets should be included in the gene panels that we used every day for characterizing KRAS, NRAS, BRAF mutation in colon cancer, and also to evaluate the mutational load. Thank you.